If you enjoy this content, please take a moment to rate and review it. Your feedback will greatly impact our ability to reach more people. Thank you.
Okay, welcome everyone to Health Further. We have a great guest episode today, Walter Greenleaf, who is a real expert in digital health. He does research and works with Stanford University quite a lot, but as I think you'll hear in the show, a lot of interactions with product development and industry as well. Walter, thanks for joining us.
I'm excited to be here. Looking forward to the conversation.
So you've had a long career in digital health, in VR, AR, what you were educating me on, XR, which would include all of the above, for years, decades even. And I wanted to have you talk about your background and maybe how you came to be interested in this space in the 80s and 90s. What drew you into the XR space, particularly as far as research as it would apply to healthcare? How did you start getting into this?
Well, in many ways, it came out of being impatient, or maybe lazy is another phrase. I was doing research in my lab at Stanford, a psychophysiology lab, studying how hormones affect mood and behavior in people. And we were recording on a brass polygraph, and this is back in the 80s. Ink on paper was how the signals that we would capture in our research, but also down the hallway at the sleep research lab. And we would measure these signals with a ruler. We would measure the amplitude of the breath or the intrabeat frequency for the heart rate with a ruler. And so, of course, with an hour a session or an 8-hour sleep study, you can't measure it all. So you take representative samples. And I just felt that I did not have the patience to do that. And I also felt it was very inaccurate to be doing that. I wasn't very precise. So optimistically, I taught myself a little bit of electrical interfacing. I got some help from some friends to hook up an Apple II computer, do the brass polygraph, and wrote some software. Assembly language programming is what we needed to do the A to D conversion to score the data. And I had a system to automatically score my data in a much more accurate way. That long story is I ended up spinning out a company during grad school to do automatic sleep stage scoring using that technology because the guys down the hallway needed that. And I learned that I enjoyed publishing products more than I enjoyed publishing academic papers.
How did that sort of first experience lead into the next thing and really trying to delve into how you could interface between technology and human behavior or human cognition?
Well, meanwhile, around the same time, my friend Gerald Lanier had started the first commercial virtual reality company. And I purchased the medical rights to his VR technology, and started using virtual reality technology as part of therapeutic processes. So I got very interested in how we can help with stroke rehabilitation, with traumatic brain injury rehabilitation, with ergonomic assessment, et cetera, using the motion capture aspects and the therapeutic potential of VR. And so that led me to getting both involved as a neuroscientist, but also as a technologist, trying to come up with some next generation medical products. Now, back then, we didn't have the same infrastructure we have for digital health, but it was starting to evolve.
Yeah. And so over your career, you have been involved in maybe 5 or 6 different research centers at Stanford and 30 to 40 commercial grade products. That perspective of kind of neuroscience, technology, digital health, building commercial grade products with academic research, what do you think advantages that gives you in sort of your perspective, seeing all these different fields and how they're progressing at different rates? How does that help you?
Well, I guess I know where the shipwrecks are, and that helps me understand where the shallows are and where you can get into trouble. But I've also seen where digital health has soared and where it's made a big difference. So, we learn from experience, hopefully. And so I've had the opportunity to work with both academic groups that are trying to spin out new technology. I've had the opportunity to work with early stage companies. And as an entrepreneur myself, I've learned the challenges of trying to do it all at once, the sales, the marketing, the business development, the regulatory approval, et cetera. But I've also had the chance to now work with some larger pharmaceutical companies and medical device companies and just get a sense as to how the ecosystem needs to have emerging technology presented to it so that it can absorb it. And that's often the gating step, is that match between what the technology can do and really what the capacity is to absorb that the healthcare ecosystem has.
Right. Yeah, that interaction between what's technically possible and what do the clinicians or patient or maybe the payers, what do they need help with? What are their really problems they need solved? That interface is where I think there's really great commercial opportunity. Is that what you found?
Absolutely. And that's often the part that I think gets overlooked, at least at the early stage for the companies that are spinning up digital health products. They see something that will have an impact, that makes a difference on healthcare, a measurable difference, and it can be validated. But that's not adequate to bring a product out. It has to fit into the clinical ecosystem. It can't add more time constraints. If you need to hire someone to maintain to charge the batteries and keep track of the inventory, that's very different than just saying, here's a product that will make a big difference. So I think it's that communication between the constraints of a busy clinic and the economic constraints of the healthcare ecosystem and the development process that's often lost in translation.
Walter, I realize that you are not solely focused on VR. You've got sort of a broad aperture when it comes to digital health, but I would like to ask you about VR because I do think in the world of VR and digital health, you're probably as much of an expert as anybody is. I think there's a lot of questions out there around the clinical purpose of VR, right? Why do we specifically need VR, right? We've got Zoom now. We've got all these people who are doing telehealth sessions, whether it's with a doctor or a therapist. What is it that is unique in terms of the property and the experience and the interaction that we have when we put on a VR headset? How is it unique with the right programming, and sort of the right oversight? How can it address trauma in a way that other video modalities are unable to?
It's a very good question. And one of the words that you used in asking the question was experience. And I love the phrase that my colleague Jeremy Bailenson uses, is experience on demand. There's a difference between reading about something or watching something or having a dialogue via a Zoom call and having an experience. And a lot of it has to do with interaction, and not just the interaction we have verbally or visually, but also our movements. And virtual environments are dimensional, three-dimensional, they're interactive, and they evoke more of a cognitive engagement. And that's the key point. The mechanism of action, to use a phrase from pharmaceutical research, et cetera, is that cognitive engagement that can happen with a virtual reality experience. That allows us to do more objective measurements of cognitive and emotional state because we're able to get more focused attention. It allows us to evoke a cognitive state or an emotional state. And if you want to measure how someone is feeling or how they're thinking, it's not enough to fill in a piece of paper or ask them. You have to evoke that state and measure that state using all the tools we have, the physiological signals, psychophysiological signals, but also observational data such as voice tone, body language. So we create a context for evaluation, and we could create a context for engagement in therapy. And it's just much more memorable, it's much more evocative, and it's much more measurable. That's the other key point is if you're in a virtual environment, we're able to not only challenging you to do something or have a multi-user experience, but we can also measure how you're reacting to a stimulus. Now, that brings some complexity. We have to make sure that we come up with evocative environments that are age appropriate and culturally diverse and not boring. There's often a lot of lamification that goes on when we try and gamify some of these virtual environments, but they're powerful tools. And I would argue in digital health that as VR and AR technology gets more out there, it's going to be the backbone for promoting adherence. And that's what we're seeing right now is with a lot of the mobile apps that we're seeing, especially in mental health, the adherence is low. People use them for a short while and then it gets a little boring or for whatever reason they stop using them. We don't see that as much with VR environments because they're more engaging, more interactive, more experiential, and that makes a big difference.
Walter, you said two things in your answer that kind of hit me over the head as like duh moments, because I don't use VR often, but I have used it. We've got an Oculus in our home. And the two things that you said, and I'm someone who regularly does telehealth therapy sessions. But the two things you said was one, immersive, and then two, focus. I'll be on a telehealth therapy session and like it's become, I have a great relationship with my therapist, so this is okay. But I'll catch myself totally distracted going into emails, and I'll also catch my therapist doing that too. And it's fine because like we have this multi-year long-term relationship where I'm not offended by the fact that, okay, like she got a text and she feels the need to kind of check on something while we're talking. It's like, it's fine. In the multi-year view of our relationship, this 2 minutes are not that big of a deal. But I think when I think back to the times when I put a VR headset on, one of the things that is so different about it than any other technology is the rest of the world disappears, right? And so it's you can't be distracted because you can't see anything else. The only thing you can see and engage with is the thing that's coming through the headset. And I think we live in this world of so much distraction right now that any engagement with a clinician often runs the risk of some form of distraction. And you could see how a VR headset alone, it's like a set of blinders. If nothing else, it does force the constraint of immersion and focus.
Yeah, you're absolutely right. And there's two other aspects of that I want to underscore. One is that, in many ways, video conferencing is exhausting, and it's annoying in ways that we've had to adapt to. Basically, staring at someone's face is a threat gesture, number one. Number two, when we're with other people, we're looking around the room, we're repositioning ourselves, we're gazing at things off to the side. We don't stare at people. And so I think there's less stress when we can meet someone around a campfire in a virtual environment and maybe walk around a bit and go for a walk together and talk. It's like, if you want to have your talk with your children about sex, maybe doing it in the automobile while you're driving and your attention is on something else and so is theirs, as opposed to looking straight at them, might be a way to do it. The other point I think is that some of the therapeutic things we do need to block out the outside world. If we're trying to help someone with post-traumatic stress, we're asking them to think about the most horrible thing that's ever happened to them or the most painful thing that's ever happened to them. The brain doesn't want to go there. And so if your clinician is saying, please think about that trauma, first of all, you can't do a graduated exposure because you have no control of what the person is seeing or thinking about or imagining. Second of all, our imaginations, and some of us are not that good at going someplace. But in a virtual environment, I could gradually take you back, and this is the principle of exposure therapy, in a controlled, gradual manner, measuring your psychophysiological responses to, maybe your fear of heights, maybe you've had bad airplane landing, or maybe you were in combat and your friend got killed and you almost got killed. And now when you see a pile of trash on the side of the road, it evokes a fear response. A clinician can gradually habituate to that learned fear response and teach you the management tools for that, the cognitive behavioral therapy perspective. But I can't do that unless I can take you there. And same principle for learning situational competence for social anxiety disorder, same principle for learning how to handle a craving and an addiction. If you need to practice saying no to your friends in a bar when they're trying to get you to have another drink. I need to be able to block out the outside world to take you there and teach you those skills. And VR is perfect for that.
Yeah, and a lot of times it's all of the experience. It's the things that I hear. Maybe if I'm afraid of crowds, it may be that when I'm in that experience, I'm hearing a bunch of people around me, and there's ambient noise, and then maybe it's a little warmer or whatever. You can adjust the environment through VR in a way that is. You'd have to have a really good imagination to be able to do. It's difficult for a therapist to paint that picture in the same way.
We can also give you positive feedback. To teach you situational confidence in a crowd, not only do I need to take you to a crowd, and maybe I do it gradually with larger crowds, or maybe it's public speaking. I can give you a friendly audience and then a more challenging audience as we go along. But we have the ability to adjust the experience based on your response. Because meanwhile, VR headsets are a perfect place to put sensors for EEG and for EMG and capture eye gaze and pupil dilation. So I can see how you're responding. And I can say, well, I need to back it down a little bit, or I need to, maybe he's ready to push on to the next level. Or this is in particular what is concerning him. So it's a perfect platform for both assessments and for interventions.
So, Walter, that reminds me, when we spoke earlier, you have 6 major areas where you think VR and AR technology can be really impactful going forward. And I thought it might just be an interesting way to sort of help the audience understand where this could go, to talk through the 6 areas. I think the first one was prevention. So maybe talk through that, and then let's talk through the 6 just briefly, where it could go.
Sure. Well, for prevention, it's really wellness. We can help teach people the skills they need to manage stress, to manage anxiety, to deal with addictions and depression. And we can do that in a wellness context, and teaching also healthy habits. One of the powerful techniques that my colleagues at the Stanford Virtual Human Interaction Lab have done is to create an avatar of your future self. And so to have a dialogue we age progress you. We show you in the context of where you might be if you're in your 20s. We can show you maybe you're in your 30s. And believe me, Stanford undergraduates seeing an age progressed future self who's even 10 years older is a little bit uncomfortable. But
yeah,
you have a dialogue with your future self about the choices you make, and then close a feedback loop. Maybe you are exercising more, your future self looks buffer and healthier. We can do that immediately. So you don't have to wait months to see the results of better exercise, better nutrition, better sleep. We can also have your avatar look and talk to you and not be very happy about the alcohol you're drinking because you decided to give up on that. And we can even have your future self give you a phone call if you geofence and go into a bar. So there's ways we can help with health and wellness by giving people feedback about what works for them, what doesn't work for them, and what their choices and values are. So prevention is what I would say is the catch-all phrase.
That strikes me as much more powerful than a payer calling me, trying to get me to do something. My future self coaching me might be much more engaging, much more likely to work.
Or maybe your future girlfriend or your future wife.
I'm not sure my wife would like my future girlfriend, but it also could be used with clinician training. One of the things that we wrestle with in the healthcare industry is keeping our clinicians up to speed on the latest, greatest new things. There are always new procedures, new technology coming out. And one of the use cases of XR technology is helping clinicians continuously train.
Absolutely. We have amazing simulations of virtual patient encounters, and you can learn to use, and it's not just, for dialogue, but also you can learn how to practice putting an IV line in. We have great surgical skill training systems and haptic feedback systems to teach venipuncture or how to do, capture spinal fluid, how to handle, and here's a critical thing, is how to have a difficult conversation. If you need to deliver bad news to a family or to a patient about a terminal illness, for example, you don't want to do that on the job and you don't want to blow it. So being able to practice in a simulation how to handle those difficult conversations is so important. So we can also train teams. I've seen some great VR applications where they're not just teaching a neurosurgeon how to plan a pre-surgical planning and to do an operation, but also have teams practice how to handle a complex situation, what to do if there's an emergency in the OR.
Yeah, so in some of the edge cases, like you'd think in aviation, where they go do simulations for bad weather or you lose an engine, we could do the same thing in medicine, where it's not expected, but some crisis happens, and how do you react to that?
Exactly. It might be something that you'll never encounter, but if you do, you need to be ready, and you need to not have it be the first time you've done it. And to do that by reading about it doesn't really teach you the skills, but to actually be there, maybe have the complexity of the situation, maybe figure out how to do it with your colleagues, how to solve this emergency on the patient in front of you. You want to practice that. So we can have the equivalent of flight simulators, and we do. We have some great pre-surgical planning systems and some great skill training systems for clinical care.
Yeah, no, 3 and 4 were better and more objective, accurate assessments, and then also improved clinical innovation. So interacting with the patient, collecting information more accurately, more objectively, and then using that in interactions in clinical settings.
Yeah, and there's a spectrum. It can run from stroke rehabilitation, both acute and post-acute, showing people their progress, showing them how to do the rehabilitation exercises correctly, making it fun and engaging. And by the way, we're learning a lot from our colleagues in the movie and gambling and gaming industry about how to promote adherence, because we can put a narrative story on top of these experiences. And for some people, what counts and what motivates them and promotes adherence is being on the leaderboard. But for others, it might be collegiality, doing the exercise or doing the rehabilitation in concert with others. Or for others, it might be learning about yourself or learning about the medical problem that you're working on. So the VR gives us a platform, and clinicians don't have a lot of time to work with patients, but a VR platform for therapy, both physical therapy or occupational therapy or cognitive behavioral therapy, gives us the ability to put that layer of I don't want to say gamification. I want to say using game mechanics to promote adherence. We can do that with VR technology.
Yeah, and then adherence and sort of distributed care. So I guess the point I wanted to make is that VR seems like a novel technology to me, to a lot of our audience, and yet you've been working on it for 30 years or so, and the broad application, it's almost across the entire healthcare landscape, and it will be a couple of years to get it integrated, but the potential is really across all healthcare. Would you agree with that?
Yeah, absolutely. I've been doing a lot of work with the Veterans Health Administration, and they're fantastic at embracing and promulgating and evaluating the value of new technologies in their ecosystem. And they've rolled out VR systems to address more than 30 different clinical indications. And they've trained several thousand clinicians, and they've had a lot of patient encounters. And so I think we're gradually moving beyond the early adopter stage. For some of the VR applications, like using it for pain medication, we have FDA approval, we have products that are out there. And again, they're moving beyond just the academic medical centers and the early adopters. They're starting to be, this is how we do things now.
Yeah. Yeah, so let's dive into that, which really likely will be the meat of our conversation. So as we get beyond the early adopter, let's test what is possible. We need to get into regulation and reimbursement. That sort of drives a lot in healthcare. And you were involved, you're the chief science officer at Therapeutics early on in the early days. And so I wanted to sort of try to frame, we have Per and Achille, who really, I think, did everything the right way. You were, of course, involved early at Per. You knew the Achille. You might have been involved at Achille. They went through the FDA. They did all the right things, and yet they didn't get reimbursement. And then we have a couple examples more recently of companies that have achieved reimbursement. And so I want to sort of try to frame this in what have we learned from Pear and Achille, and you were in the middle of that. So let's talk through that. And then what are we seeing even in the last 2 weeks about sort of, there might be a light at the end of the tunnel. Like we're starting to see a couple pathways where it can get through regulation and get reimbursed. But let's start with the lesson. So you were early at Pear and Achille. What is the takeaway from that? Or what should we learn from those?
Well, I think appropriately so, there's a lot of inertia in medicine. And there have been a lot of false starts trying to roll out digital health applications. And Corey McCann and my colleagues at Pear did a fantastic job of bringing to the existing regulatory infrastructure the establishing software as a prescription medical device, SAMD. And I think that broke the ice in many ways and opened up a lot of doors. I think timing, though, is everything. And I think the timing of Pear's entry into this and when it went public also coincided with changes, a downturn in our economy. There's many reasons to, in Silicon Valley Bank and so many things that can push back against companies in this space. But the reality is, in my point of view, Pear and Achille and others did a great job of opening the pathway. And we see there's fantastic examples. But our regulatory environment and our reimbursement environment relies upon research and relies upon validation and relies upon demonstrating the clinical efficacy and the business effectiveness of these new therapeutics. And sometimes that takes a while. And I think we'd all like to have a more responsive system when something new is developed, that there's better pathways to move it forward. But it does take time. And that's one of the reasons I've really enjoyed working with the Veterans Health Administration. Reimbursement codes aren't...
Right. They got a bunch of veterans they need to take care of, right?
Yeah.
So Walter, that begs the question, how is it going at the Veterans Health Administration? I mean, like, what kind of penetration do we have of VR devices? How many patients have been seen and been treated with these software medical devices? And is there any outcomes that have been reported? I know that you are working across the spectrum, whether it's pharma or providers or payers, in the research capacity, kind of in more of the commercial, GovPay space. But as you said, with the VA, I mean, they can kind of just do whatever it is they want to do, and hopefully we're finding some great outcomes there. What's reportable from the VHA?
Well, they're in the process of assembling the metrics about the economic impact and the clinical impact of the products. But they have stood up systems across every state, every VA hospital, and most of the clinics have some form of VR. And again, over 30 different clinical indications, many different products, and they're in the process of moving that forward. What I understand from my conversation is that, on top of the thousands of patients that have used VR therapeutically, on top of the thousands of clinicians who have used it with their patients, the reports are extremely positive. The patients like the products. They don't want to turn them back in. They want to take them. The clinicians feel that they're extremely helpful in terms of reducing some of the time burden and allowing them to do more for their patients. I think the next level is going to involve better ways of interfacing to the existing infrastructure at the Veterans Health Administration in terms of their EMRs, et cetera. But we're getting there. And I encourage you, maybe bring back Ann Bailey, who has run the Immersive Therapeutics program at the VA for your podcast, because she's made a big difference there. And again, I think it's not viewed as this exotic technology at this point. It's viewed as something that we're adapting it to match the needs. And to some extent, we need to embrace some of the new tools that we have with generative AI. The products that are being fielded right now were from a previous generation of graphic design and artwork where things had to be, a lot of effort went into creating the experiences in terms of, like building a video game, very expensive, very time consuming. But now with generative AI, we can dynamically change the background information. So if I need, as a clinician might want to do exposure therapy in a kitchen that was set in the 1950s in the Deep South, we can do that. We don't have to use the one-size-fits-all approach for the experiences that they're using. So it's moving forward, and fantastic results. I would also say, if you look at the what we're seeing with many of the products receiving FDA clearance, and a lot of published work demonstrating the clinical efficacy of the products, we're well over a threshold of, does it work? Is it useful? Is it cost effective? But now I think we're at a stage where we're just making sure that it fits into the clinical ecosystem.
Yeah, so in the last couple of weeks, there's been two news items that I want to talk with you about, because I think Pear really sort of pushed forward and established software as a medical device as a thing, and it got approved by the FDA, and I was celebrating. Everyone was celebrating it, but then CMS decided not to reimburse for the tool, which is their purview, but was surprising, because previously other devices, when it had been approved by the FDA, had been reimbursed. And so we now have this new environment where someone who wants to bring a new device, new VR tool forward, you have to go through two gates, which are independent, or at least not directly linked. You have to get through the FDA to make sure it's safe and effective, but then you have to make the business case that it should be reimbursed. And a company called Applied VR actually established themselves with the VA, just almost exactly like you and Marcus are talking about. It's a solution for back pain, and they have had great results. And they found a slightly new approach. It's a very small change, but I want to cover it because we have a lot of people listening that either are in administration or with payers or doing a startup. And so they filed that they were creating software in a medical device as a wholly contained package. And so the software is inherently part of the hardware device, and they linked the hardware and software through the breathing as measured through the microphone, I think. So everyone will have to look at their own products, but it wasn't a huge leap. It wasn't a brand new device infrastructure, but they did intentionally connect the hardware to the software. And I think that was important to CMS. I'm not exactly sure why, but I'm not sure it matters why. So that's one pathway. Now, if you sort of can connect,
I think it's durable medical equipment.
Yeah. So this software and hardware combination, and the hardware aspect is the measuring of breathing through the microphone. That is what has been approved as a durable medical equipment device that CMS is willing to pay for. And Highmark is paying for, one of the Blues is paying for it. That is pretty interesting, because there are other VR, AR tools that might take that same approach. And if it's a way to get reimbursed, get a code and get reimbursed, that could be really positive. So let's talk about that. And then there's another pathway too that we'll talk about around DeepWell too. But let's stick with that first. So does it make sense to try to integrate the software and the hardware together as a package, not necessarily for effectiveness, but because it will be it's more likely to be reimbursed in our existing situation?
I think that's a pathway. I think that especially for Applied VR's work for chronic low back pain, I think that is so key to be able to get those systems out. And once validity has been demonstrated and economic impact has been demonstrated, then that's a good code to use. I think there's also work being done using some of the remote patient management codes for some of the products that are provided at home to help manage someone with their therapies. And then I think you're also, Vic, about to bring up some other code.
Yeah. So the other example, and that's good, which was Deep Well, which you brought up to me. They're really a game developer, but they have gone through the FDA 510K process, really around their engagement, game mechanics, how their algorithms work to drive adherence, and they wanted to do that in order to be ready for the behavioral health codes that are coming out in 2025, which are more like remote patient monitoring or chronic care management. That they are codes to allow clinicians to monitor their behavioral health patients over time, and there's a fixed amount of money for that. And some of these deep well algorithms or embedded in other tools could be really helpful in that, which is another way to sort of get reimbursement in a different pathway than you would otherwise.
Yeah, I think the concept here of establishing a particular game mechanic, to use that phrase, that is promotes adherence or that promotes results, I think that's really very key, because we're going to come up with more and more complex ways of providing mental health, behavioral health, rehabilitation, telerehabilitation products. And we need to understand, as these get skinned with different layers on top of them of interactivity and experience, what is the core part that is promoting results? What makes it impactful? What makes a product that complex enough to have it be a patient's having an experience rather than just taking a pill or measuring something, that's so important for interventions and therapies. But what is that key mechanism of action, to use that phrase? What is the mechanism of adherence? What is the mechanism of action? And can that be approved as something that the FDA says is substantially equivalent to a biofeedback device, for example? And that provides a pathway to be more generic, that we can have other products come forward and say, we don't look like that other product because of the top layer of what we're doing. But if you look at the mechanics of what we're doing, here's the mechanism of action, and here's why it is. Here's why we can make claims about its effectiveness, because we've validated that mechanism of action. So to me, that's burrowing underneath and finding the active ingredient to a therapy, which I think is so important. I love it.
Yeah, and I have some empathy for FDA and CMS. I mean, they are trying to assess now, this big wave of new, largely software tools, and they don't have a good way to measure that. So if they can find the active ingredient, I love that analogy, like this is what they're really focused on, that might make the approval process faster and more effective.
And in many ways, that harkens back to the approach that Pear Therapeutics had, is they were looking at previously researched and validated digital health applications that had gone through extensive evaluation. And then they were taking something that might have been developed 10 years ago and using Flash as the context and moving it to the current generation of technology, but preserving that active ingredient. And I think that's a key point. And I think as we move software deeper into how we reach people, which we have to do with an aging population, with some of the healthcare crisis, we need to leverage technology. We need to figure out what is the key part to look for both validation, for regulatory review, and also for reimbursement. And that to me is the critical part, is coming down to that core part of what makes something effective. Can we measure that part? Can we extend it to other products that are coming out?
Walter, over the course of the 30 years you've been working in VR and healthcare, how have you seen the regulatory agencies, and let's maybe specifically focus on the FDA here, and maybe even just if we were to time box between your time as chief scientific officer at Pear to today, how have you seen the FDA mature in its ability to assess these technologies, right? I mean, technology is always going to lead regulatory agencies, so there shouldn't be some expectation that the regulators are ahead of the tech, right? But the tech is moving faster and faster and faster. We are getting, more consumer grade VR out there on the market, which inevitably would mean many more developers are working on these types of technologies. We're already seeing the backlog of AI, submissions that are at the FDA. So what have you seen in terms of the development of talent focus initiatives inside of the FDA to be able to properly assess the efficacy and safety of this technology?
I think we should be proud and congratulatory of how the FDA has risen to the occasion. I mean, they would and we would love everything to go a little bit smoother and faster, but they have really, looked at as the tech titans, Apple, Google, Samsung, all these companies are moving into healthcare. Things are surging forward, and to look at the black box of large language models and machine learning to make a clinical decision and being able to regulate that when it's when the data sets behind it change dynamically, that could have been something the FDA said no way. We need to be able to see all the wires and all the parts and be able to then and they've said we're gonna get on top of this. So my impression is very, very positive. Now, I should say I'm not a regulatory specialist. It's not what I do. But what I see in terms of companies coming to the FDA seeking review, and I see the new divisions being set up within the FDA to rise to the occasion, it just seems like they're on top of it. And I also see our healthcare ecosystem trying to rise to the occasion too. I've seen United Health Group has done some, and with Optum has done some fantastic work with accepting digital applications, and then worldwide too. I mean, look at what's going on in Germany. There's some really fantastic work there to systematize and organize and reimburse for digital applications. So, I think there's a lot we can be frustrated about. Of course, things can, there's hard-working groups that come up with products, and then, and they know they make a difference, but getting the pathway to market it can be a challenge, but I think we're rising to the occasion, and we really have to. I mean, with an aging population, with the crisis of burnout in our clinicians, with the crisis of mental health in our youth, we've got to leverage technology to solve these problems. And so, yes, I'm feeling positive about how our agencies have responded. But, I'm sure they would like to move faster, and we would like to move faster too. But I think we should applaud them for the work they've done.
So, Walter, I was listening to a speech you gave, I think it was to the VA, and you touched on the changing role of the clinician. And so I'd like to end with, you've seen this market evolve from really nascence to a pretty exciting space today. Where is it headed? And particularly, maybe let's focus on what the clinician's role is going to be as these new tools come out, and there's all kinds of data sources and technology tools. What is the clinician's function in that system?
It's a very important question, and I think it's a dynamic between good design and also changes in the roles and practices of clinical care. I remember at the beginning of our call, I talked about the product I made on the Apple II computer. Well, when we moved from the Apple II to the Macintosh SE, I found there were a lot of clinicians who not only did not know how to type, they didn't know what a mouse was. And that was because back in that day, everything was analog and handwritten, and we made fun of doctors and their handwriting. Now we have EMRs, and if you are a doctor who doesn't have a computer in the room while they're talking with you, you wonder what's wrong. Why aren't they leveraging technology? So things change. I think now with AI coming in, with these systems that we're talking about that allow you to manage a whole spectrum of your patients and see how they're doing, We can have a dashboard that is red, yellow, and green, and nuances to that, with feedback on the patient status and whether it's time for someone to come in, or whether they aren't doing their exercise, or they've fallen off the charts somehow. There's much more information about patient status and progress, but we need to make sure we design these dashboards and we provide the information to the clinicians in a way that's not burdensome and is palatable. And that's a design challenge that the product developers need to have. But we also need to, as clinicians, there's a need to appreciate that the role is changing, that there's a lot more information about the individual stage as a patient. The patients are showing up with data from their wearable sensors, and they want to integrate that into what you're seeing as a clinician. I think clinicians are becoming more of experts who can provide advice and leverage, the technology that's coming out, like digital twin technology and simulations, and integrating information from disparate source to make the right clinical recommendation. And that means both getting on top of new technology, but new technology needs to get on top of what the clinicians need to see and how they, make sure we don't overburden them. So it is complex, but you're right. The role is changing, and I think we need to make the stair steps to make it not a big leap, but a gradual evolution of how we practice medicine today.
Is it fair to make the analogy to financial planning that, like, I go to see a financial planner and they'll sort of talk to me and try to learn about what my goals are, but then they have a set of tools that they can advise me on and pull in a mixed set of things to match what I need. Is that close to what a clinician will be doing in the future, where they meet with me and they try to understand where I am now? They take readings on various, biological markers, and then we together sort of map out a plan, like, buying stocks and mutual funds and things. I don't actually do that. I sort of talk to my advisor, and then they go do the things. It may be that the doctor or the set of clinicians that I work with, they're more sort of partnering with me on these things. They're experts at certain things, but it's more of an equal, I'm talking about what I'm willing to change and what I'm willing to do and what my hopes and goals are, and then they help me get there. Is that close to what you're painting as the picture?
Oh, absolutely. I think that's a perfect description of the optimal pathway. And I think that the key part of what you said that I think is so important to reinforce is the part about understanding the patient's goals. All too often, we have algorithms that if you have this measurement, if you're in this age group, here's the therapy that should be provided to you. But really, patients do have different goals. Some may want to optimize for getting back to work sooner. Others might want to optimize for a longer lifespan or health span. Others their priority might be to have more time for more ability to do something else. So the clinicians need to, and we need to design into the dashboards and systems we build, the ability to have a patient reflect their goals. And it does also need to be portable, that if your clinician moves to another city, that the information and perspectives are available to whoever is stepping into her place. And it also needs to be, I think, we're still evolving some of the interoperability issues among our digital health technology. So I think that's part of the problem, to allow a clinician to have that helicopter perspective and make the recommendations. I think in many ways our banking system is a little bit more structured, and our financial system than our healthcare ecosystem in terms of the evolution of digital healthcare technology. There are, groups, wonderful groups that are putting together ways of standards and interoperability, but that still is something we need to work on. But I love that vision, and I also think it's more than just being the advisor. I think you're also the coach. The role is partially to say, here's what we know, here's the expertise, I can give you information, and I can help you think it through. But also, it's not easy. Healthcare is not easy for the patient, and often it's a challenge. It's especially when it gets rough. So I think we also need to see, and they're currently doing this, but we need to preserve that as we move forward, that empathy, that willingness to care for your patients and help them find the best pathway. We need to make sure the layers of technology we put on top of that doesn't get in the way of that.
Yeah, almost empower them to be empathetic and spend more time with the patient, coaching them, and because they have these technical tools that allow them to do so. Right?
Exactly.
All right, so Walter, maybe I'll get the final word in here. You've come across throughout this interview as a very pragmatic person. However, just to have a little fun, I'd love to get a prediction for next year. You know, last year we went pretty in depth into the end of pair because I think we were both concerned. We have a track record of investing in digital therapeutics successfully, and we were pretty concerned about sort of what the long-term implications of the end of pair were going to be. And then kind of out of nowhere in the last month, we've seen some really great signs that digital therapeutics are kind of back on the rise from an investing perspective and reimbursement and relationships with payers and things of that nature. So that's really good. You know, having you in the seat here, what do you think we as investors should be on the lookout for in 2025?
I'm rarely accused of being pragmatic, so thank you for that. I would say that I love the quote from William Gibson, the future is already here, it's just unevenly distributed. There are some remarkable things that have been developed and are on their way in all full stack of healthcare. And it's all, you know, based on digital technology. AI is giving us a lot of jet fuel here. And we have no choice. I mean, we have to move these systems into our healthcare ecosystem. And there are some wonderful breakthroughs that are occurring. So for 2025, I would say it's not a time to pull back because things are just starting to surge forward. I think it's a time to find the ones that are doing it right and you know, follow them. But there's more. You know, these are the advanced scouts for you know, a tidal wave of digital health applications that are going to transform healthcare. And I think that we know that's happening, and it's something that, yes, there's been setbacks. That's just part of how things go, and some of that is an aspect of our healthcare ecosystem adapting to these amazing technologies. But I see a gathering momentum. I'm very positive about where things are going. And I wouldn't hold back right now.
So one of the things you suggested to me when we were speaking before is that the Gen AI tool set is getting more and more powerful every day, and it's relatively inexpensive compared to the old way of doing these VR environments. And it might be a business model to watch to have a free tool out there that would be much lower regulatory approval, of course, no reimbursement approval, in order to gather very large numbers of user data, see how it's making a difference. And then you have a premium track, like a normal freemium model, but it's really more around the efficacy and the business case to get reimbursement that you were saying that could be an interesting business model to watch.
Yes, what I'm advising my clients who are bringing out new digital healthcare products is that there's a wellness component where the claims are different and the application areas are different, but the data they're collecting can be tagged and used to empower products that are on the clinical side of things. And that a bimodal approach, it used to be the investors would say focus. I think, sure, focus, but make sure that you leverage the power of numbers and data that we get from wellness applications, use that to build out the foundation of data and analytics for more clinical facing applications. I think we'll see more companies doing that. The other thing to look out for is AR technology is soon about to take off. And we had Google Glasses and things like that, but the next generation of AR is going to be low cost, comfortable to wear, powerful, And there's going to be clinical applications on top of that layer of technology too, that I think is we're going to see transmedia applications. It's not just going to be desktop, laptop, cell phone, and watch. There's going to be applications that span all those technology platforms to provide better healthcare.
Great. Well, that's a good roadmap. We have plenty to invest around that, I think. Walter Greenleaf, thanks for doing this. Really enjoyed it. We'll need to have you back to talk about AR as it comes out. We can all be wearing new glasses in 6 months or 12 months.
That'll be fun. Next time we'll meet in a virtual world to have this conversation.
Yeah, that's a good idea. It's a good idea. Okay, thanks, Walter. Appreciate it.
Take care, guys.